Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Hi, all. Just before we start our episode here, I just wanted to jump in and give a little bit of a trigger warning. Today, we are talking about eating disorders, disordered eating patterns, and we are going to use some language that might be triggering to people. So we use the term fat, we talk about weight, we talk about body dysmorphia, and psychological concerns when it comes to eating disorders. So just pay attention to that. Again, protect your peace if you know this is going to be triggering. And at the very end, and in our show notes, we will link a bunch of resources for places where you can get help if you feel like this is an area where you might need to have some help. Hello, and welcome back to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge.
And we have a really important topic we're talking about today, and I think it's a pretty big one, so we're just going to jump right in. We're talking about disordered eating and how it relates to life and fertility, and we have a wonderful guest with us this week. We're so excited. We are welcoming Judy Simon to our podcast, to The Whole Pineapple, and Judy practices as a registered dietitian nutritionist, certified health education specialist, and adjunct faculty at the University of Washington. She owns a private practice, Mind Body Nutrition, specializing in reproductive nutrition and eating disorders. Judy co-developed the successful Food for Fertility program here at Seattle Reproductive Medicine with our very own Dr. Angela Thayer, and is recognized as a fellow of the Academy of Nutrition and Dietetics and as a national leader in the area of fertility and nutrition. Judy offers her patients the unique experience of non-dieting, intuitive approach to healthy eating. Judy's professional contributions garner national attention from the nutrition and fertility fields. The Academy of Nutrition and Dietetics awarded Judy the Excellence in Practice in Women's Health in 2014, and the Community Practice Award for Excellence, Washington Academy of Nutrition and Dietetics in 2017. She has been invited to speak on nutrition and fertility at the American Society for Reproductive Medicine, Academy of Nutrition and Dietetics, Pacific Coast Reproductive Society annual meetings, and served as the president of the Seattle-Tacoma Reproductive Society and past chair of the Nutrition Sub-Interest Group of the American Society of Reproductive Medicine. Judy, is there anything else that we want to add?
That's a mouthful, which is very appropriate for someone talking about nutrition.
Somebody so awesome.
Oh, thanks. I think it shows how old I am, possibly too. But we won't
Judy, you're just one of my favorite people. I refer to you with a lot of my patients. I've presented with you at conferences.
Yes.
I love hearing you talk about all this, and I'm so happy that you're willing to come talk with us today.
Thank you so much. So excited to be here.
So I think, this is such an important topic, and it's one of those things, it's kind of like fertility where it's a big thing and it affects so many people, but no one talks about it.
Yeah, exactly.
And I was so excited when you invited me because, it's really cool that you have a wellness program. And, we like to think of wellness as everything happy and good, right? We're doing all these good things for us. And sometimes, this is my lead into disordered eating. People may feel like they're doing the best things, but they're taking it way too far to an extreme. Like they're trying to eat as healthy as they possibly can. So they heard to cut out gluten and cut out dairy and cut and exercise more and, push yourself to the limit. And then that very same person wants to start a family and they're just shocked when they don't get pregnant because they're so healthy. What could possibly be wrong? They do everything right. And then eventually they show up at your door. They may show up at a fertility clinic and they look pretty good, right? They tell you they eat well. And hopefully the providers that they work with and their assessment may find out that this person, may have an eating disorder or disordered eating that's really having a negative impact on their fertility.
And I think it goes the other way too, where sometimes we have a patient that comes in for fertility care who used to have a pretty good relationship with food, but because infertility is so much about loss of control, and our patients start looking for, well, what could I be doing? What could I be controlling? I'm doing everything right and I'm still not getting pregnant. And so I think sometimes we even push people into a disordered pattern because they're just looking for something they can change in their life. And then, as you said, they start off with might be a healthful change, and then they just keep trying to alter more and more because it's one thing that they do feel like they have some control over.
Absolutely. Absolutely.
I was thinking about that before we knew you were coming on for the talk, and there is so much overlap, but I know at least in our clinic, we don't have a routine screening questionnaire for disordered eating. We ask people about so many other things in their intake paperwork, but we don't ask everybody, and I feel like actually we probably should.
We do
So,
with our
yeah,
PCOS.
you do.
We do with
You do.
PCOS, but we don't for
But
everybody.
not
And
for
as you said,
everybody.
if someone comes in and presents, it is something where we might not think about it, where we may not even occur to us to ask until we're pretty far down the fertility journey path.
It's interesting because you think about healthcare, reproductive healthcare. When a person is pregnant, we're all concerned about screening for gestational diabetes and screening for all these things. And OBs barely ask if you've had a past or current eating disorder, which could really impact your pregnancy. The same thing preconception with fertility. So I know that what I put on my intake forms that people fill out before they even come in is I ask a question right under stress and all those other nice questions, depression. I ask them, do you have a past or current eating disorder? And a lot of people check yes. They don't even have to go into detail. And then when it comes to my weight section, I have changed it to say optional. And I think I'm going to even go one step further and say, have you, noticed a change in weight that you think might be impacting your health? And sort of leave it as an open question, because it might be someone who said, yeah, I gained 20 pounds during COVID and here's why, versus someone who has some other weight related issue. So kind of almost normalizing it, that we're not going to judge you based on your BMI, but who are you and what's going on in your life?
Yeah, I think that's really important. Those open-ended questions, I find I get more information from those than almost anything else because it just gives the opportunity to present that information that they otherwise would have just filled out or checked a box and moved on from.
Yeah, especially I know we're in the process of redoing our intake forms as we move to a new electronic system. So we have to check and see because we should have, I think, a question for everybody because so much of what we do in fertility can sometimes be triggering because it often involves weight gain. It involves bloating and hormones. And if you have someone that's already trying to track that to a degree, I always notice that in my paperwork. We often, on our current forms, we ask, what's your typical weight? What's your current weight? And if I notice that somebody says typical weight and then says their current weight is like 2 pounds higher than that, I'm like, that's someone that's very fixated on exactly what they think they should weigh if they feel like they are 2 pounds over what should be their ideal weight. So
yeah, leaving that open-ended really does invite the dialogue, which I think is really important too. And I don't know if you've done your intake. I find one that's really helpful for me is food intolerances and allergies. And if you've got a story there, there's usually something more to dig into and find out what's going on. Why does this person have 52 allergies? And maybe it's legitimate, but I think those are the kind of easy entries to having those
I like the idea of even putting the box to give you the weight as optional. I think that's a really great way of explaining that you're here to help and it's not all about please tell me everything that I ask you for.
And I think that helps us as decreasing the weight bias, before you even see the person up, high BMI, low BMI, whatever.
Yeah.
And that kind of leads me to, you don't know when someone walks in your door, what does a person with an eating disorder look like? And, there's a lot of shame with an eating disorder. Someone who's binging and purging and they're coming to you because they want to have a baby, the first thing in their mind is not to share these behaviors, which could really be medically dangerous, what they're doing on a psychiatric level. Also, a lot of shame. That's probably the eating disorder, I think, with the most shame. Anorexia, a lot of people think of, oh, that must mean the person has a BMI of 15. Well, guess what? There's people in fat bodies that have anorexia. They are truly, truly starving themselves. And we have had a number of people join our Food for Fertility class who let me know ahead of time, let their provider know ahead of time that they don't want to be weighed, how they want to discuss weight. Some of them will share like, hey, I have been through eating disorder treatment. And I was starving myself. And then you're looking at them like, oh, that person, weighs over 300 pounds. They truly were. That caused, their amenorrhea and contributed to their fertility, no matter what their size is. So they're letting you know ahead of time. And then I've had people, those same people, check us out. Our class is, well, will we talk about weight? Well, how is food talked about? And it's worked out beautifully. And so I think that we have to kind of check that bias that everyone with an eating disorder is either looks cachectic. You can be malnourished at any size.
Absolutely.
At any
Absolutely.
size. And so if you can pick up on something, that's when you want to refer them, for an assessment. But if you have a minute and you're talking about lifestyle in a casual way, you could say, can you share with me what you ate yesterday or what a typical day looks like? And that might be really telling. And when I told one of my patients who wants to share her story, I was doing this podcast and on the topic, she said, please let the listeners know that I saw 15 different types of providers from, natural medicine to, you name it. I saw them. She said, very, very thin appearing person, an hour and a half of yoga a day, 4 miles of walking. And she goes, if some asked what I ate, and it was an RX bar for breakfast, a salad for lunch, a small dinner. So maybe it was 1,200 calories. And how active I was. And I hadn't had a period since I was 15, went through 2 retrievals with terrible quality results until she finally went to a sports medicine doctor who said, get yourself to an eating disorder, get some help, got help, and conceive naturally.
Oh.
So not to say the person doesn't have any struggles, but, we really have to look at people. I don't know. I look at everyone with an eating disorder lens. Eating is all over the place, behaviors, thoughts. We have a lot of pressure from diet culture right now.
I was going to say, I think it's almost probably more rare in our current culture to be an adult of reproductive age and have a healthy relationship with food. I think
Absolutely.
Were you raised on a commune somewhere? How did you not absorb all the messages that we have right now in society?
Yeah. And when I was preparing for this and kind of going over my past notes, because I teach about eating disorders in my nutrition counseling class for graduate students at the UW, these eating disorders, true eating disorders that meet the DSM-5 criteria, these are psychiatric illnesses, okay? And they start early. They usually didn't start at 35 when this person shows up at your clinic. They probably started at about 12. And it might have been maybe an athletic, person with ovaries who went on to college and she wasn't athletic anymore. And she put on some weight and kind of freaked out and kind of did some extreme dieting, so there's a lot of comorbidity. The comorbidity rate of other mental health issues with eating disorders is like 85%. I mean, you will rarely see someone who's been diagnosed with anorexia nervosa, which is a restrictive disorder. You will rarely see anyone who doesn't have anxiety, depression, or OCD, or maybe all 3 of those.
That makes total sense.
Let's go into some definitions. Do you want to break down for us what are some of the types of disordered eating? I know you mentioned anorexia and bulimia.
Yes. So anorexia nervosa, which although more common in people with ovaries, it's more common. But people with testes also have it too, but much more common. I think it's just more frequently diagnosed. I think it exists in all genders. And we actually see a higher rate of body dysmorphia and eating disorders with trans men and women. And I see a lot of those folks at the university, a lot of body dysmorphia. So anyways, if we start with thinking about anorexia nervosa, there were some changes in the diagnostic criteria. Guess what? It used to have menstruation. Well,
not everybody menstruates, and
right.
Not everyone menstruates. So that was dropped. And they really changed the diagnosis that it wasn't by BMI or not having, but actually characterized by weight loss or maintenance by extreme dieting, starvation, or excessive exercise, right? Probably one of the most common referrals I get, I know at the UW, is secondary amenorrhea. And it will come from the endocrine folks who are working up people, the medical endocrinology. It will come from the fertility clinic, and it will come from sports medicine. So these folks often have multiple stress fractures. They came back from a marathon with really bad hip pain and they had 3 stress fractures. Well, how does that happen? Really, really low estrogen levels because constant energy underbalance, meaning they're not eating enough. Their bones are really, really impacted by this. So I'm seeing 19-year-olds with osteopenia and moving towards osteoporosis. So that's really pretty severe. And then, so you can imagine if that's happening to their bones, what's happening to their uterus and their ovaries. So often you'll see maybe on an ultrasound hypogonadism, you'll see those small ovaries and thin lining, and that reproductive axis is really asleep because it's the last place to get energy. So you can see how that restrictive eating over time, and remember, a lot of times this is happening, it's starting in high school or grade school.
Yeah, and your body is going to conserve energy. You know, it only has so much energy coming in, and it's going to use its stores and go towards the vital functions, your heart and your brain and your vital organs. And reproductive organs, eggs and sperm, tend to be the ones that aren't high on the list when they only have so much energy to
When
go
you're being
around.
chased by the tiger and you think you're in this true like life or death
Yeah,
situation.
Absolutely. And I actually show my patients sometimes a diagram of that, where the energy is going. And the other questions, for health providers that, a lot of health providers will tell me, oh, well, I'm not a specialist in eating disorders. I go, you don't have to be. If you're a clinician and you're listening to your patients and you notice they're pretty bundled up and you ask them, what's your temperature like? Do you feel cold a lot? And they're like, yeah, I need 4 blankets at night, right? And if you're hearing, oh yeah, I have Raynaud's, everyone always says, oh, my feet are always cold, my hands are always cold. Those are signs of a lack of available energy. So you mentioned, Ruby, heart, lung. Okay, that's where our body. So you'll often see a low pulse on some of these folks. So you might say like, whoa, oh yeah, I'm a runner. My heart rate's 42. It's okay. But when you're getting into the 40s, and then if you ever see like a glucose level that the blood sugar is like 60, well, that's not normal. That is not normal. That means you have so little glycogen stores. So those folks are not ready to go through fertility treatment. They're malnourished, okay, no matter what size they are. And not every fertility clinic has the resources. And that's when you need to identify like, hey, we can help you be fertile, but first we have to take care of your malnourishment and your fear of eating and have an assessment, with a therapist and a primary care doctor and a dietitian that can work together as a team. And hopefully, if you're the first intervention, which is awesome, they can get that help on an outpatient basis. Otherwise, some people can't. Some people cannot eat enough. And so with eating disorders, we talk about levels of care. And it really hits home with anorexia nervosa. Some people, they cannot. I mean, I've had patients look at me across the table and just say to me, okay, I get it. I go over all that energy stuff, right? That we just talked about, how important it is to have enough energy, or you won't have any hormones and we can give you hormones, but it's not the same. You won't have enough lining, all the things that, you're shortchanging yourself on. And then they'll look at me, they're like, that's okay. I guess maybe I could eat more and exercise less, but I don't want to gain 1 pound. That rigidity. I don't want to gain 1 pound. I'm staying at 100. Now, these are the same folks that want to get pregnant, but I'm staying at 100. So when you hear that, I'm not a therapist. I've gone through decades of training with eating disorders. I train dietitians. We work as a team, because this is really, truly a mental health illness. And it is so liberating when you're that person who gets the help and finds new ways to cope or deal with trauma or whatever some of those underlying issues are. We've helped a lot of these folks have families. But what I feel bad is when someone comes to see me that's had 3 failed IVFs, and they're like, oh, I don't know what to do. I don't know why they can't get better eggs out of me or whatever. That might be the point where we really have to say, you need to have treatment, or it's going to be really hard to get pregnant.
You brought up a good point too, because of us, we might be the first one that maybe picks up on this. And it is, I know as a provider, sometimes you do get a little bit hesitant to go into the realm of eating disorders because you don't feel like you're an expert, but to know that you don't have to be an expert. The biggest thing is to get that person the help that they need. And that's where it really helps to have a team that you can refer to get these people the help that you might be able to provide yourself.
Yeah. And I'm sure we'll talk about resources at the end, because I do want to share like nationally, because I know this podcast goes all over the world probably. How do people get that help and how would a clinic? But I think that you're in such a unique situation, Ann and Ruby, that you're talking periods, right? You're talking periods. So you get to talk to them about, what's it been like, when's the last time you had a natural cycle? And if it hasn't been since 15 and, doing the appropriate type of workup. And it's sort of interesting when you look at those people with ovaries who have amenorrhea, it's estimated that about, probably 3/4 of people with anorexia nervosa have amenorrhea. Okay, so there's a really strong link, right? And when we talk about bulimia and binge eating, we see secondary amenorrhea too. The hormonal connection, we're trying to understand, we're not quite there. And when we talk about folks with PCOS, a metabolic syndrome, 3/4 of them have insulin resistance, right? So a few years back, probably 5 or 6 years ago, everybody started making those aha connections between bulimia, binge eating, and PCOS. And let me tell you, there is a lot of overlap. So I was invited to 3 or 4 of the local eating disorder centers we have in Seattle, said, Judy, come educate us about PCOS, because I was working with it in the reproductive world. And like, wow, that makes sense. These women with binge eating, probably 2/3 of them have never been diagnosed with PCOS. Mm-hmm. So they get really hungry and they have insulin resistance. So when they go through eating disorder treatment in a program, they're being fed regular balanced meals. They feel so much better. And that's part of the treatment for binge eating disorder, is really to help people be competent eaters and eat regularly so they have less. So seeing that. And then on the other side, I've been privileged to also do lunch and learns for several of the reproductive medicine clinics, fertility clinics in the area, and talk about eating disorders, because both of those are kind of my wheelhouse. So there's so much intersection. And is that something that you all saw as your careers went on, like that overlap, like, this connection?
Definitely. Yeah. And as you said, there's so much overlap. And I think we have had a bias in the past where we've associated so much of it as being linked to those that are in larger bodies and that it's all related to body image. And that's why there's this disordered eating, and not realizing that, everything it's a circle, and realizing that even people that might present in a very normal BMI doesn't mean they don't have a very unhealthy relationship with food.
Absolutely. And I'm so glad we're getting this message out. I just feel like it's so important that we just have to treat each person as an individual and keep that lens, open for it, especially with PCOS. It's talked about so much more that I think it's a woman with PCOS is like 6 times more likely to have an eating disorder.
Yes.
And I think that part of the problem is, it's getting better. These folks need to be diagnosed much earlier. Mm-hmm. Yes. And a real workup, not just, you can go on the pill or do this and come back when you want to get pregnant. And I'm sure you're going to talk more about PCOS and future topics, but the idea that if folks really have a good assessment, mental health, physical, nutrition, wellness, they're just going to have just a better quality of life. And I think we should see less eating disorders in this population.
And you mentioned earlier, before, seeing people at younger ages. Is that something that you see in the research as well? Are we having higher rates of disordered eating even in middle school? Yes. I just think about social media and, my daughter being 13, everyone's got their cell phones, and it's just such I thought when I grew up it was hard, but it's not any easier now.
No, and you're so right. All of it's getting worse. And I contacted 3 of the local eating disorder programs this week, yesterday or whatever, just to get I knew that the waits are really long. Some of the programs are like 3 months to get into residential, 2 months to get into the day programs. People are pretty desperate. And when I started in this field about 20 years ago in Seattle, We had almost nothing. We had one not so good outpatient program, and the last hospital-based program closed because these programs are so expensive. And a small program at Children's, people used to have to go to California, like you had to leave the state.
Wow.
Now we have in Seattle 4 or 5 major centers with all levels of care, and many of them are connected that if they couldn't get somebody in local in Seattle, you could go into another state. Eating disorder care is expensive, sounds like fertility. Horrible insurance coverage, getting better. The same thing it used to be if someone was on Medicaid, you were just out of luck. So things are getting better, but some of the same hurdles. So we want to help people sooner so they don't have to be in a higher level of care.
And I think that is one of the worries. I think sometimes people are afraid to seek help because they don't want to be sent away to some, we
Nobody
saw
does.
we saw the scary movies. We saw how you don't want to be. And so I think people don't always realize that there are many of those levels of care that you mentioned.
Yeah, I remember like a while ago, a lovely nurse was referred to me from a clinic, and it just came out in the first session, terrible bulimia. And I want to explain what bulimia is. So bulimia is actually binging, overeating excessively, and purging is most commonly vomiting. Okay, self-induced vomiting. Sometimes it's laxatives, not nearly as often, and sometimes it's excessive exercise. And people have no idea that there are people that will binge at night and the next morning they're like, I'm going to work out for 3 hours. I mean, so think about it. So this eating disorder takes over your day. You're either thinking about food or how to get rid of the food. Okay. And I see it a lot with trauma and all. So anyways, this patient hadn't shared with her husband, and she shared it all with me, and she really wanted to get pregnant and had PCOS. And I said, would you just talk to an eating disorder program, a really nice one in town, and just get an assessment, because she was a healthcare provider. And she talked to them, and I got a call from them the next day, and she's like, she's coming into the program, and she was there 3 months, came out, said, oh my gosh, I'm so glad I wanted to get pregnant, or I would have never done this. And then went on and had a healthy baby in the next year, I think naturally, So it was such a good story. I just said, we can't talk about fertility when I'm really worried about your quality of life. Yeah. And so the laxative abuse is less common. Purging is probably the most common. And then probably the new kid on the block, but it's not a new kid on the block, is not till the DSM-5 did we recognize binge eating disorder. It is an eating disorder. Okay.
So talk about how that's different than bulimia. What is the difference? So where you're not having any purging.
Yeah. So with binge eating disorder, people are eating a large amount of food in a small amount of time. It could happen any time of day. I've had patients tell me at the end of the day, they haven't eaten all day. They had a really horrible day. They go through the drive-in and they buy like $50 worth of fast food, and they literally eat it in the parking lot until they feel sick. So the difference about binge eating is people don't do the purge. They don't vomit. They just feel terrible. They feel horrible. The next day they wake up and they don't feel very good about themselves, so now I can eat the next day. So there's a lot of triggers for binge eating, and dieting is the biggest one. Mm-hmm. Okay. So I'm kind of one of those hashtag anti-diet culture people, because all these diets that say eat at a certain time of day, or don't do this or don't do that, and have so many rules, people don't trust to be attuned to their body. Mm-hmm. Okay. And so your cortisol levels are up, your circadian rhythms are off. I work with a lot of folks in fertility. Oh my gosh, those poor night nurses, people that work night shifts, 12-hour days.
Oh, I remember.
I do too. Yeah. And you have the 2 a.m. someone runs to Jack in the Box because that's what's open.
Right. Or just survival eating or not eating.
Yeah. I was on the opposite. I wasn't hungry.
Okay. So Ruby, I see a lot of folks like that. And so sometimes I would find that these people would come home after that 12-hour shift, third day. They're so exhausted. It's like anything they could eat, and then getting into some really bad rhythms. So sometimes the circadian rhythms. And so I think with binge eating, I think, some of the data is old on the numbers, but the problem is that's the one eating disorder that most people don't get treatment for. Mm. It's just like, you look at the person, oh, they're overeating, they feel ashamed. And honestly, treating for binge eating disorder, which should have definitely a psychological assessment and all, those folks don't necessarily have to go into treatment. They can also get a lot of help in an outpatient setting. Okay. So I think that's really good. So the punishment of that is all, and that can affect cycles too. But bulimia and anorexia are really the ones that if somebody's having secondary amenorrhea, they used to have cycles and they don't have cycles, you want to know what they're eating. And my very favorite patients are you ready? When they send them to me and they go, okay, hypothalamic amenorrhea. So when someone is not having a menstrual cycle, they send them to me and they can't figure out, are they lean PCOS or do they have an eating disorder? Do you love those, right? Like, what do you think? And so the docs are like, Judy, I don't know, find out what they're eating and what they're doing. And that's where we can really listen for that energy balance. Maybe they're really athletic. Are they eating enough? I've seen women with ovaries, people with ovaries, I've seen them have anorexia, no cycle, they gain the weight back, they get their cycle, and then we find out they have PCOS. So they kind of hate us in one way because sometimes they keep gaining weight. I mean, everything was kind of flattened out, the hormones. And then when they got fed, we saw a whole different profile. So many things can be going on, which is why I always try to send people to either fertility clinics, OBGYNs, or endos that I know are going to do the deep dive. I know I can say, hey, this is what they're eating. I think there's an energy imbalance. Let's look at some of the labs and let's really try to figure out what's going on with this person.
Can you talk a little bit about why you use the word fat instead of saying something like obese or overweight? I know.
Well, because, what do we say when somebody's thin?
Yeah.
We don't say, oh, I think she has a BMI of 18. I think it's a BMI. We just say they're thin and that's culturally acceptable. So just using the word fat is a descriptor.
Yeah.
So I do use, and in the health at every size world, they don't use obesity. They don't want to hear about BMIs. They don't want to hear about obesities. So it's not a negative thing. Fat is not a negative thing. We need fat in our body, right? And
it just tells you what it's like in our society that it's so jarring to hear it. Like to just hear somebody say, and then when they got fat, because we're so just culturally attuned to think, oh, you just insulted somebody by saying they got fat, because we have so much built up in that word that thin is on one side and fat is on the other side.
We need fat. It's physiologically, we need fat. And honestly, if you don't have enough fat, you can't have a pregnancy. We need fat. It feeds us. It keeps us warm. It cushions our organs. And I guess, that physiology 101 is what we have to teach people, because I've had people with SMA, that small mesenteric artery syndrome, where literally they have no fat pads left between their organs and they can no longer swallow. Everything has collapsed because there's no fat left. So I've seen what malnutrition can do. And that's the road that, anorexia or disordered eating can lead you to.
Thank you. I just wanted, I heard you talk about it. And I think that's one of the other problems is I feel like the cultural perceptions out there of disordered eating are almost always the stereotype of anorexia, you're thin, you're rich and you're white and you're being controlled by your parents and all the teen movies that I saw back in high school. But that's still what's more commonly out there than something like a binge eating disorder, or the fact that, as you said, it affects bodies of all different sizes.
It does. And in fact, in the eating disorder professional world, there has been the hugest effort, and they're being very successful the last few years, to find therapists, dietitian, doctors who are BIPOC, they're people of color, they're queer, because who wants to go see someone that you don't think has any connection? There's actually a newer clinic down in Tacoma that is just offering so much, sliding scale, being more available to people.
So you brought up the biomarkers. So you're right. Like those are stats. They're used by medical professionals to help us make decisions for your care, but that does not define you. And I feel like sometimes it has gone to the way where we are making judgments about somebody's character and who they are as a person based off of their biomarkers. And that happens a lot with BMI. And you've probably had so many people that were referred to you for PCOS who said, well, somebody told me I had PCOS. So they put me on birth control pills when I was an adolescent, and that was it. No one talked to me about the whole body approach to PCOS. They just said it's a reproductive issue. Call me when you want to get pregnant, kind of thing. But they were labeled PCOS because they had irregular cycles and that their BMI was high. And that's it. That does not, nowhere in the diagnostic criteria for PCOS is BMI. that is not part of the diagnostic criteria.
Yeah, so true.
I'm sure you had the same thing as I've had. Sometimes people do come in and they tell us they have PCOS, and we have to explain that they actually don't. They actually maybe have a diminished egg supply, and that's the reason their cycles are irregular.
Yes.
And you feel awful because they've spent all this time also believing that they are having these struggles for a completely incorrect reason. And I mean, PCOS is its own topic that we're definitely going to want to get into address.
Yeah, and our assumptions, like as healthcare providers and as society, like putting those judgments on people, it negatively impacts all areas of life, including fertility.
I know I have, whenever media, TV shows, movies do the eating disorder storyline, it's kind of like the same thing as when they do the fertility storyline. I'm like, oh, here we go. They're going to like resolve everything in 3 episodes where there'll be a little bit of a struggle, but instead of gazing at the pregnancy test, they're like gazing at the scale, and they're just going to like show this real quick and easy descent and then arc, and they don't really represent the variety of what's out there, as well as, again, I want to make sure people get the variety of treatment, that there are so many different ways to get people to have help, and especially now with so many people doing remote and doing Zoom and counseling. And so although there's still a great role for inpatient care, I think we have more options now than we ever used to for people to get help from their own home.
I so agree, because people have licensure in more states. So I work with like an excellent psych nurse practitioner, and she's in New York, but she's licensed for California, Washington. So knowing the network, and there is a good network, and I have to tell you that like right now, Children's is so behind in their adolescent program. I actually asked them to please take my name off the list, but I still get families that call me, and I just have a list ready and I send it to them, because I will do anything to help those families, because they are trying to get help.
Yeah.
They're trying to get help. So I will help them. Can I share a study that was just published in a French journal of reproductive health?
But in French, of course. We want your accent.
I took Spanish, so you're out. No way, man. Prevalence. It was a prevalence and phenotype of eating disorders and assisted reproduction. So these are people already at a clinic. It was a systematic review. So they looked at the articles, the journal articles that were reviewed. They were looking for the prevalence of eating disorders in infertile patients, but these folks are already undergoing assisted reproductive technology. So IUI, IVF, medicated cycles, B cohort or case controlled studies. So they found 15 studies, and they're all quite different. And the prevalence really, there was a big range, but they found overall that there was 6 times higher evidence of eating disorders in infertile patients undergoing fertility treatment compared to regular pregnant women. However, they said diagnosing these conditions is complex. As a result, it is essential that professionals need to be in contact with this population or alert to symptoms and signs. And I think that's what we can do, that everyone who is, working with folks trying to conceive. And when we talk about the people with testes, guess what? They have eating disorders too.
That's going to be my next topic. I was like, let's get into that side.
Yeah. So, Anne, I'm curious, because I know you see those folks. I get just a trickle of referrals, and sometimes they have really extreme eating disorders, and they've been on a really crazy extreme diet. So their hormone levels are just plummeted, their testosterone levels are really low, hypogonad, stuff like that. And I find they're not always so excited to talk to me. Like, they're not like, yeah, bring it on. I could be part of the issue. So I'm curious what your experience has been with that.
Yeah, I mean, I think it does show just that we're not asking enough of the right questions. As you said, our intake paperwork for our PCOS patients, we ask for a diet recall, but there's nothing like that on a sperm intake paperwork. I don't think we even really ask about nutrition. And I know when there is an issue, often we will screen for diabetes. We'll talk about healthy lifestyle in vague terms, but we certainly see a lot of people who probably meet definitions of concerns with over-exercising. And they may not be actually using steroid products, but they are at the gym to a degree. And, sometimes they're on a ton of supplements and powders and things that they probably are impacting their hormone levels as well. But no, I agree. We don't really talk about it nearly enough. And I know you mentioned a lot the dysmorphia. We do see that. We see people that are so built and obviously spend hours at the gym and feel like they are in terrible shape. And it's hard to have a conversation sometimes about reality there.
And I'm curious, do you see those folks too, Ruby, sometimes in clinic?
Yeah, no, probably not as much as Anne, but absolutely. I think there is one question on our intake form that says basically describe your nutrition, or just, I think it even uses the word diet, but describe your diet. And half the time, so for the partners with sperm, usually what they fill out is they fill out like their name and maybe their height and weight and their family history, and that's it. And then if they write anything on that, what describe your nutrition, it's usually like regular or normal. And you're like, well, what does that mean? So, and oftentimes they're not on the new patient visit, so you can't explore that as much.
Got it.
I feel like we get the most impact when we do our PCOS visits, because since that's really focused on wellness, and we have them do a 3-day diet recall. And often when we're doing those consults, I do often, if they have a partner, both people are usually together, because if you're going to try and really talk about eating patterns and exercise patterns, that's something that if you have a partner, it's much better to do it together.
Oh, it's so much better.
It doesn't help the situation so much if one person is really committed to trying to move off of processed foods and cook more at home, and their partner's like, forget this, I'm going to the drive-thru.
Yeah.
So you really do want to hopefully address it together. And I think that's probably the side that we're getting at least a little bit of that conversation. But I'd love to hear what else you know about it.
Yeah. Well, think about the scenario too, is I always wonder if I'm, working with, a person with ovaries who, to me, is so diminished in their body weight, and it's so obvious how little they eat. If they're in a relationship, where the heck is the partner? Where are they? So I always, if we can involve them, whichever gender, that partner may be, doesn't matter. And then I want to know what's going on with them, because I'm thinking, well, if this is normal to you to be eating so little, what's going on with your partner? And that's probably impacting their fertility, if it's a heterosexual couple. So depending. So looking at that too, I think is really, really important. But there is a men's clinic at UW, and I get a trickle, but they just don't follow up as well. Or I give them some advice and like, okay, I'll check back in if I need to. So it's a little bit, I don't know. Sometimes I find like it's so easy to put the fertility on one gender and not the other.
That's what I was going to say. I feel like it's like all things in fertility, how as long as there's enough sperm to start treatment, people are like, well, we'll do IVF, or, we'll do IUI. And that's kind of the end of saying, hey, well, why are these things this way? Is there anything else we could be doing on that side to optimize the outcomes?
Yeah, I think that some of the best conversations I have with people with sperm are those semen analysis phone calls that we do when they ask like, well, how can I make my sperm counts better? I say, okay, well, let's talk about wellness. And like, that's one time where I actually get like 5 minutes to say like, oh, here's what we need to be doing. But that is not enough time to get really a lot of information. And that's not the point of those kind of visits either. But often, yeah, we just don't have the opportunity to talk as much.
Do you have stats at all, Judy, of like what the rates of disordered eating are for those with testicles? Or
let's see, I do. Let me get back to you on that. I've got numbers flying all over my head.
So Judy got back to us with a little bit of stats. She said that the lifetime prevalence for those that identify as women is about 3.8% for disordered eating, compared to 1.5% for those that identify as male, although there is a thought that it's probably underdiagnosed in that population. And those that identify as gay men have 7 times the risk of reporting binge eating and 12 times the risk of purging behavior. So just pop it in to give you a little bit of numbers and context. And thank you, Judy, for giving us those stats after the fact.
Speaking of stats, can I share a really important one with you, though?
Yeah, of course.
Globally, this was good. Globally, and this was published in 2019, that between the years 2000 and 2018, the rates of eating disorders went from 3.4% to 7.8%. Okay. Wow. So, and higher in Asian countries. In Japan, Taiwan, China. I see this with some of the foreign graduate students I work with. If they gain a few pounds, they're like, oh my gosh, if I go back home, my auntie's going to think I'm so fat. I mean, really. So some of the culture, some of the media, some of stress, but that's just insane. And the growth of the number of eating disorder programs shows a need. Maybe we're diagnosing better, but it seems like, more prevalence. Because I started in this field decades ago when I was in graduate school, when it had to be really obvious. It had to be, purging or starving yourself and ending up in the hospital, and really kind of working with a psychologist and psychiatrist. And when I was working in college health, and it was just kind of all new. And we know a lot more, but I think we have to work so much more in prevention Obviously, we're talking about fertility today, but there's just such an impact on people's fertility from years and years of being undernourished or punishing themselves, and the harm that it's doing to their body and how it's just shutting down their reproductive access.
I find it interesting that people feel okay to comment on people's weight at any size. When has it become okay to comment on somebody's size?
Right. And you bring up a good point. So for someone who's intentionally losing weight because they're restricting,
Yeah.
this happens to a lot of folks, especially in college or after college. They lose weight. You look so good. They're like, well, I'm starving myself and people are now noticing me. I'm dating. People are noticing me. And what's interesting, so you have this conundrum in the wellness world, okay? We want to do the best for everyone, but that's not the same for everyone. So honestly, like I'm working with a teen right now, and what we do is, one of the things we do is family-based therapy, which is great because it works. So teens get to stay at home and the parents are in charge of feeding them. So they get a big plate every meal. Half of it is what we call energy food. It could be potatoes, rice, pasta, whatever it is. A quarter of it's veggies, and they have their protein. They have all their foods to fill it out, and, someone's medically monitor them. But my point is, we take the control away from them because this is evidence-based. Their families love them and they can trust their family to feed them. And we talk about why we're doing it. Well, then we get to the point that we expose them to fear foods. Okay. So then, Ruby, I get to do the opposite thing. So if somebody is really scared of a bagel or a cookie or something, we go through that challenge. And I work with their therapist on what we're going to use as challenge foods. And, am I telling them I want you to eat unrefined carbs or whatever? No, I want them to know that food is pleasure.
Yeah.
And it's going to be okay to eat everything. And so I always tell the folks that are going through eating disorder treatment who want to become parents, I go, you know what? You're going to be great parents because you're going to really learn that exposing kids to all foods, you could put the dessert on the table with dinner. That's going to help decrease your child of having an eating disorder. There is some studies looking at some genetics of anorexia. I have families where mom and all the daughters had anorexia. And one gal, I've known her since she's 16, and then went on the pill because she wasn't patient enough to get her period. And boy, she came back at my life at 25. And she fought it with osteopenia, very active. And she finally said, okay, Judy, I'm going to just do it. And she did the deep dive into, all in, stopped exercising, just walking. And in 3 months, now we're getting regular periods, but she knows how much she has to eat. Okay. So that's a 10-year journey. Because she kind of just put it on hold. It didn't go away, is what I'm saying. And she wants to maybe have kids. I think, okay.
Well, I think I didn't really quite understand the whole idea of intuitive eating until I had kids, and then seeing when they're little before you've messed them all up, and you realize that you can see them have a dish of ice cream and eat half of it and be like, I'm full, and put it down.
Done.
And they're like,
yeah.
I'm done. I don't need that anymore. And you're just like, oh boy, when did I forget how to do that? You forget that you do have this innate ability to listen to your body and what you actually want and what you don't want.
Yes. Oh, and I'm so glad you brought up intuitive eating. So what we have to do when we're treating folks who have eating disorders is, first of all, we have to help the malnourishment, the physical part, the mental illness, and just get them eating every 3 hours or every 2-3 hours so they can get back to physiologically feeling like, what does normal feel like, right? So a lot of folks with anorexia, they don't even know hunger and fullness anymore. It's just so broken. Those neurohormones are messed up. So we get them feeding, and that's what they do in treatment. I mean, they feed you and you eat with everybody else. And if you can't finish the meal, it's not poured down you, but you got to drink it. So, you really have to do it. Once you get to that place that you're feeling safer and you're not scared of the food and maybe the weight gain or whatever had to happen to recover, then we can start helping them be a competent eater, making sure they have the skills and resources, right? It can be easy, helping them with that as a team. And then they can go on to becoming intuitive eaters, which to me is the best because you have to dump diet culture. You have to give yourself permission to eat and be able to do that. You can work on those skills of identifying hunger, fullness, joyful movement, not movement for punishment, but doing whatever the heck you like because it feels good. We can give folks idea, but they have to try it out and they have to see if they like it. Like telling somebody to run in a treadmill when they hate it, don't do it. Who wants to do that? So that's the tenets of intuitive eating, but honoring your nutrition too. And so in food for fertility classes, yeah, we learn about foods that can help promote fertility, but we let them try it out.
Mhm.
Hey, we're doing farro this week, and then people will come back like, farro's so good. I didn't even know it existed.
Hmm.
Like, try new things, check it out, but you still get to be satisfied. And when people
Yeah.
feel empowered, they're more likely to seek out that help and assistance.
Mhm.
But we have to, like, say, ignore diet culture. It's all about money. It's all they want to do is make
We
money.
want people to feel whole. That's our whole thing.
It's so funny you bring up like trying different foods and like things that are
Mhm.
nourishing and things like that. I like farro. I
Mhm.
love farro, by the way. But one of the things that always makes me laugh is avocado gets put on this little pedestal. It's like,
Yes.
and so, which is all well and good, avocado, but I hate avocado. Like I like guacamole. I am not an avocado person. And
There
every
you
once in a
go.
while I'll be like, I just have to eat some avocado because it's good for me. But I'm like, do I? Do I? I don't. I don't.
No, there's a lot of
Yeah.
other stuff too. And so that's honoring, what we taste, but the exposure is important
Mhm.
too. And so you probably notice, those of you who have kids, you notice that, like, sometimes they go to daycare and go to school, like, oh my gosh, they're eating beans. They don't eat beans at my house, but they saw the other kids do it. And
Yeah.
so you want to expose
Yeah.
kids to it. We want to do the same thing with us and
Mhm.
adults. So while people are going through treatment, or people are trying, when we talk about eating healthy, that doesn't mean, eating grass. It means really finding foods that you like. And on the journey, you're not going to like them all. And that's okay. And some are going to be extra delicious, and learning what is satisfying. And I think that's why, since 1993, there's over 125 studies supporting intuitive eating. Okay. And how can you be healthy at every size? And I do want to say, on a happy note, many of the women in fat bodies that I have worked with, and so many from our program, from Food for Fertility, some with disordered eating, some with true eating disorders, really started to do the work, to do the therapy work, to nourish themselves in a way that you have to feed yourself faithfully. That means you have to wake up in the morning and you have to feed yourself, and you deserve to eat just like you water your plant and you feed your dog and your cat and everybody else. Everybody needs to eat, and learning how to have that better relationship with food is so important. And so we've seen women who weren't cycling and were going to get ready for IVF, who didn't eat all day with PCOS because I wasn't hungry, because I didn't break that cycle after 6 weeks. I go, well, what did you get out of this program? Well, I started eating during the day, and I got my period. And then a month later, got pregnant. Really being kind and compassionate to your body. And that doesn't, everybody's going to be in a different journey, and it's going to take different amount of time for different people. But, that there's always hope that you can have a better relationship with food in your body. And I think if we can teach people that lesson, then I don't want to see 6 times as many people, have eating disorders, because now they want to get pregnant and their bodies are just really having a hard time. That's a piece of the puzzle. There's a piece of, workup, and we have to acknowledge it, and we can't tell people to just lose weight. And we all learned, right, Anne, on this journey, we know more about weight than we did 10
Yeah.
years ago in
Yep.
fertility, right?
No, that's beautifully said, Judy. I mean, I think that's exactly the message that we wanted to get across today.
Oh, good, good. There is a national organization, NEDA, NEDA, National Eating Disorder Association, which is just a great website for people who could get information, signs and symptoms, if they're concerned about someone. It will give them resources. There's a hotline. That's a good place to start. For those of you in Seattle, we are blessed with an amazing
Mhm.
eating disorder community. And you're welcome to use my email. And I'm actually on a lot of groups where we do even weight inclusive eating disorder. And we know who's available and who takes insurance and stuff. So definitely connections. I always appreciate phone calls or emails and helping people. I think that the most important thing is the local eating disorder programs, and most of them, except for OPAL, which is Smaller Center for Discovery, Eating Recovery Center, Emily, a lot of them are national programs, so you will find them all over. They have great information on their websites. You can call and ask questions. Patients can have an assessment. It doesn't cost anything. You know what I mean? There's places. And then I just got something, I think, from Center for Discovery, education for providers, because I'm hoping that some of the people who listen to this podcast are nurses, dietitians, embryologists, who are like, well, I didn't get much
Mhm.
training on eating disorders. I just got this whole booklet. They have all these free on-demand webinars that you can watch. I get a lot of education from free, it's all free, from the Eating Recovery Center in Denver. which accepts the sickest patients. They like one-on-one care, the sickest patients. I just had someone go through it this last year, and the person's doing phenomenal, spent 8 weeks there, but just so critically ill. They know how to help. And most of these clinics, as a provider, if you were kind of worried about a patient, you could call and you could talk to a doctor or a nurse practitioner there, and they would give you some advice. Like, I don't know if we should refer this patient. They'll help you out. So there is a lot of help in the community. There's a lot of good help. We need more insurance. But I think all of you and your job is to kind of normalize the behaviors, but really do that deep dive and let them know physiologically what's going on. They go, well, we know a way we could thicken your lining and you could have your period, and it takes nutrition. How do you feel about that? Like, open it up from a medical perspective. Here's a treatment we offer. Okay. You would probably benefit from working with a therapist and a dietitian, trained in eating disorders to help you. Do you know what I mean? Mm-hmm. So I think if you as providers could normalize it, yeah, a lot of people have eating disorders.
We will post all of these resources in our show notes and on social. And I actually just looked up, so nationaleatingdisorders.org, so NEDA, right on their opening page, there is an option for online chat for an 800 free phone number, so toll-free phone number. And you can also text, which is so accessible. So super great. And then they have a crisis line too, in which you can call or text. So really, really great resource. We will definitely put in the eating recovery too.
Oh, thank you for doing that, Ruby. You will help so many people just by having that resource. You have no idea. Just normalizing it. This is something that exists. There's help. That's really, really important.
Well, Judy, we could talk for hours and hours with you. I know you have so much more even to share with us, but I really appreciate your time. I think this is such a crucial topic, especially as it relates to fertility that doesn't get enough attention. So thank you so much for coming here and answering our questions and sharing your wealth of knowledge with us.
Thanks. I feel so honored to be on this podcast. I've already been sending it out to my patients and to be, one of the early ones. So I feel just really, really fortunate. Thank you.
Oh, absolutely. Thank you so much. And thank you everyone for listening, and be sure to tune in on Saturday because Judy will be back and we are going to be talking about health at every size.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.